Jumping into Chapter 7, Nutrition and Nutraceuticals. As your book says, eating is a part of daily life. A growing body of evidence supports the use of nutrition as therapy in health promotion, disease prevention, and both as well as disease treatment. We know that nutrition therapy can be effective and efficient treatment when the medical condition affects nutritional needs, or if the diet affects the medical condition. When nutritional considerations are part of the plan of care, we as healthcare providers will help our patients feel better, improve their management of their healthcare, and can help avoid complications that are ultimately going to decrease quality of life. So this chapter examines the role nutrition plays in pharmacotherapy, including the role of food intake on drug pharmacokinetics and the use of nutraceuticals, which is by definition foods that have claimed to have a medicinal effect. What I have learned through my years and years of being in healthcare and being in this role is 1,000%, I believe very strongly, how nutrition can impact the body. And I have seen and witnessed firsthand people that take on a very nutritious and healthy eating lifestyle, and they have reduction in their symptoms of some of their diseases, especially when you're talking about autoimmune diseases or chronic inflammatory conditions. I am a big proponent of this and a big believer of the importance of nutrition when it comes to our health. And one of the greatest disservices we have done to Americans in general is our processed food and how easy we have made it to eat unhealthily. And so this is a very good chapter because it really helps hone in on the use of food as nutrients. But most importantly as well, we have to understand how food works in pharmacokinetics, right? How does our body break down drugs and how does food impact that? So this, our chapter, these are our objectives. We're going to describe the significant nutrient-drug interactions, identify individuals who may require nutritional supplementation, and discuss the importance of the nutraceuticals when prescribing medications. Kind of the overview is studying nutrient-drug interactions, nutritional management, nutraceuticals, food, and how it can affect, and the different drugs may affect nutritional status. Food may affect the drug's absorption, the drug metabolism, and the drug excretion within our bodies. So having the nutrient-drug interaction understanding is really important. Drugs do not create new bodily functions, but rather they interact with cellular function. So the supply of needed nutrients is key to adequate cell function. Because some drugs are designed to improve altered cell function, it seems logical to conclude that nutritional factors can then affect pharmacological therapies. Healthcare providers are concerned about the effect of drugs on the absorption, transport, metabolism, cellular uptake, and excretion of nutrients, and the effect of nutrients on the pharmacokinetics of the drugs. Some food can contain chemicals that may directly compete with medications, right? And we know, for example, when we think about people who are on warfarin and they consume a large amount of vitamin K, it makes warfarin inactive. And so it makes the drug less effective, right? So the food is directly competing with the medicine in that situation. So drug-nutrient interactions must be considered to use drugs effectively and to get the outcomes we're looking for. So obviously, patient education is going to be one of the most important things that we can do. Again, education, it always comes down to that when we're helping our patients understand the nutrition, food, and drug interaction. So the first thing to talk about is drug absorption. So the most frequent type of drug-food interaction is when food works within the GI tract. So the effect that food has on the GI absorption of drugs. So drug absorption can be decreased or delayed, but it can also be accelerated or increased by different foods. So drug absorption takes place across the mucosa of the GI tract. Okay. The proximal part of the small intestine plays a significant role in drug and nutrient absorption secondary to its large surface area. So it's not just like in the stomach, it's actually also in the small intestine, especially in the early small intestine, like the duodenum. Drugs utilize the same transport mechanisms as nutrients: passive and facilitated diffusion, endocytosis, and then active transport. So the nutrients can also be competing with the drugs in that way as well. So food in the GI tract at the time of the drug administration then is going to affect absorption and bioavailability. Several physiological factors affect drug absorption during the transport process. So bioavailability, remember, is the percentage of the drug available to produce a pharmacologic effect. So several physiological factors like bioavailability, pre-systemic metabolism, our gastric emptying time, concentration gradients, and the absorptive surface area we have to work with. All of those physiological factors can affect drug absorption during the transport process. One of the ways that the food impacts this, like we said in the GI tract at the time of the drug administration, is because it changes the gastric emptying time through the interaction within the GI lumen and then by competitive inhibition. So remember, food can increase or decrease absorption, and it can accelerate or slow down absorption, right? So there's both ways that it can happen. Food will decrease the amount of fluid within the GI tract, thus slowing down drug dissolution. But lack of food for an extended period of time, so if you take it when you're fasting for a day, for example, that can decrease the absorption secondary to vasoconstriction. Gastric emptying time, then, we've talked about, will influence drug absorption because the longer the drug is sitting in the stomach before it's allowed to pass out of the stomach is going to impact how long it's exposed to the pH of the stomach. But there's also a lot of variables there, whereas it's how the drug is prepared, if it's enteric coated or not, for example, what disease you're treating, the age, and the need for pre-systemic metabolism or dissolution. And then if you think about it, disease states like ulcerative colitis, Crohn's disease, and celiac, or if people have had bariatric surgery, we have now found ourselves in a situation with altered gastric emptying time. Also, infants, children, and pregnant women also will have considerably different gastric emptying times. A drug that requires interaction in the stomach for disintegration and dissolution would have reduced absorption because of the rapid gastric emptying time that might accompany a fasting state. Also, delayed gastric emptying time that might occur with a high-fat meal would facilitate drug absorption because the drug is given more time for maximal disintegration and dissolution. So takeaway point regarding drug absorption: if you have a patient that's not getting the desired effect and they say they're taking the medication, it's important then to question them about the food intake and how they're taking the medication may be related to food, or especially if that's something you did not teach them about before. So food may bind with drugs and may decrease the absorption. And the example that your book talks about is tetracycline and like milk or things high in calcium. Food facilitates the absorption of some drugs. And then patient education is going to be key to proper medication administration and taking it the right way. The other example the book talks about is that the bisphosphonate Fosamax, which is alendronate, it demonstrates a 40% decrease in bioavailability when taken with food and a 60% decrease in bioavailability when taken with coffee or orange juice. So we know that in order to take that drug, you need to only take it with water, right? I mean, you're literally not going to get the proper effect of the drug if you don't take it the right way. The potential for the change in drug absorption by food or nutrients is high in the GI system. So that's an important one for us to understand. The next thing the book talks about then is the influence of food on drug metabolism. So we've talked about how we could absorb it based upon the interaction of food within the GI tract. Now we're talking about the rate of drug metabolism. And now we are working in the GI tract and the liver can be affected by the nutrition intake. A low-carb, high-protein diet may increase drug metabolizing enzymes. Increasing intake of antioxidant cruciferous vegetables can also increase the activity of these enzymes. So we can see clinically examples of the effects of food on the metabolism every day. So you can have a large variability in the response based on how we're metabolizing the drug in the liver and the GI tract and based on food. We also know then that the CYP systems are at play here as well. So the CYP system is the major enzyme group responsible for the metabolism of foreign chemicals that come into the body. And we can remember this hopefully from pathophysiology. So your CYP system is the major enzyme group responsible for the metabolism of any foreign chemicals that come into the body. So we have learned a lot about the CYP enzymes and how they work within the body in the last 10 or 20 years. Information continues to grow about the clinically significant interactions between food and drugs utilizing the CYP450 enzyme system. The CYP450 system also has a significant amount of polymorphism associated with it, meaning there are differences between individuals in the presence and or function of a particular enzyme group. So from person to person, they can have unique metabolism based on their CYP450 enzymes. Grapefruit is always evil on a board question. That's what the tip and trick I can give you. If you ever see grapefruit as an option, it's probably the right answer, that it's terrible to take with drugs and medications. The book also here talks about the Seville orange and pomelo juice because they influence the metabolism of many drugs because they contain components that inhibit the CYP3A4. The ingestion of these also can lead to increased levels and adverse effects of calcium channel blockers, the different immunosuppressants, erythromycin, triazolam, midazolam, and then the statin drugs. It's safe to say you should avoid the intake of grapefruit juice or these things within 4 hours. So if at 7 o'clock in the morning you take a cup of grapefruit juice with breakfast, you need to wait till 11 to consider that the grapefruit is out of the way. Also, grapefruit juice increases systemic exposure of oxycodone, which I hope people never learn about in the general public, because then people are going to be chugging oxycodone, or chugging grapefruit juice if they're on oxycodone and looking for a high. There are some drugs that have a very narrow therapeutic index, like theophylline, that would have specific warnings about certain nutritional intake or smoking or other things because it's such a narrow therapeutic index. So there are some drugs out there that do require a lot of education about taking it and avoiding certain things like food or cigarette smoking. So when we talk about influence of food on drug excretion, certain foods can change the urinary pH, so that can increase or decrease the amount of the ionized form of the drug or metabolite. So example that the book talks about is like gentamicin would be more likely to be reabsorbed in the renal tubule when there's an alkaline pH. That's an example. So there are some drugs that can alkalinize the pH, like milk, vegetables, and citrus fruits. But then we have foods that can acidify the urine, which is meat, fish, cheese, and eggs. So how can drugs influence nutrition, or drug-induced nutrient depletion is where the book talks about next. So before, we've been talking about how nutrition and food intake can alter the drug, but how can drugs affect our nutrients? Okay. So drug and nutrients could be that the drugs can have an effect on our nutrition and our nutrient absorption, how we synthesize, how we transport, store, metabolize, and excrete the certain nutrients. So the side effect profile of a drug taken over a period of time can be related to the effect of that drug on nutrition depletion. This is a huge area of research. A lot of information's out there, and it's continuing to be studied, and I think we'll continue to learn more and more. So just as food can alter drug absorption, excretion, metabolism, etc., the presence of drugs can alter our body's normal way of processing our nutrients in a bad way. So GI changes due to dietary factors that affect drug absorption can also be induced by drugs and therefore affect nutrition absorption. So it could be a two-way street. The example the book talks about is that you can change your pH from antacid or potassium therapy. You can reduce the absorption then of folic acid, iron, and B12, for example. The other example is phenytoin reduces the level of folic acid by inhibiting the intestinal enzymes needed for folic acid absorption. So many metabolic pathways will rely on specific nutrient availability. So if we have a drug that alters that nutrient availability, we can have a deficiency in cellular function. Like the synthesis of vitamins can alter our coagulation factors, or neurotransmitters can be affected by the reduction in nutrient substrates as well. The book also talks about loop diuretics then cause depletion of sodium, calcium, and potassium levels, as we know, which is why people on furosemide, a loop diuretic, often are on potassium repletion automatically. So the outcome of nutrient-drug interactions. We have to be aware of nutrient-drug interactions because if the expected outcome of the drug, so the reason we're giving the drug therapy, we aren't getting the outcome we're expecting, or we're having a more profound adverse reaction profile, then we have to know how to investigate and think about it. And one of the things we need to look into is nutrient-drug interactions. The book says these things. Could the patient who became pregnant on the low estrogen birth control, could that patient have a reduction in drug bioavailability due to food intake? Right? So the other question they ask about is digoxin. Is the digoxin serum level low in a patient because they had an aggressive bowel care regimen that had a high fiber intake that altered the absorption of their digoxin? Of course, we have some common ones that you may see like in board questions that we have to be aware of. We all, I'm sure by this point, are aware that warfarin and the INR can be very much altered by vitamin K containing foods. So they have to follow the strictest of diets. The MAOIs, monoamine oxidase inhibitors, had to avoid tyramine containing foods. This was a terrible diet to follow for people. It was very challenging. Luckily, we don't use MAOIs much. They're really fallen down to like very specific reasons for using them. You've probably heard like metronidazole or Flagyl. You're going to get really sick if you drink a lot of alcohol while you're taking that medicine. And then caffeine and alcohol can also have a potential effect on drugs as well. Alcohol can either induce or inhibit the CYP450 system enzymes. So that's a big deal, right? This is why understanding your patient's nutritional intake is very important. When you go on to health assessment, one of the things they were going to teach you a lot about is doing a good nutrition assessment. And it is very important because we understand there's nutrition-drug interactions potentials. It's also important to ask about alcohol. It's not because we're trying to judge anything, But if you were having 3 glasses of wine each night with dinner, I have to know that because that could be impactful of how I prescribe your medications, for example. It is important to understand people's caffeine intake because there are drugs that can be altered because of high caffeine intake. So having the time taking the time, to ask these questions is really important. And sometimes people get irritated with me when they're like, why do you care about my diet and my caffeine? Well, because we really do have nutrition drug interactions, and we have the capability of making you really sick if I prescribe medications assuming that you're not taking alcohol. So I do need to know, for example. Okay. So how are we going to manage this as providers? We're going to recognize drug-food interactions exist. We need up-to-date resources. We need to seek proper education material for the patients. And then we need to phone a friend. We have to work with our nutritionists, our dietitians, our pharmacists, those people that this is their area of expertise, to rely on them to help us understand. And they are great educators to the patient. We are very spoiled in bigger healthcare systems now that we typically always have a nutritionist, a dietitian, or a pharmacist around. So if I'm prescribing like warfarin, for example, as a provider, and I'm rounding and trying to do a bunch of things with my patients, I can consult the dietitian or the pharmacist to go in there and do the education for the patient to help them understand their diet interaction with this new medicine. So we're going to work with our friends and other interdisciplinary team members. And again, we're going to get a complete patient profile. You guys have heard me yap about this, I'm sure, before, but I'm going to take this opportunity again. If there's anything that you remember from ever having me as an instructor, it would be one of the things is my soapbox. It is so vitally important to have a process in place, how you practice, that allows you to do a complete med rec on your patients every single time. It is by far and away the simplest and most straightforward way you are going to directly improve patient outcomes. Even as simple as that sounds, it is not. It is such a rushed paced atmosphere in medicine these days. So if you're in an outpatient heart failure clinic and you're trying to turn and burn your patients, you've got 8 people on your schedule, they each get a half an hour. There's so much to talk about in that time. How do you do that, right? And if you're seeing them once a month, maybe they get tired of you asking. There's so many things that go into it. But if you, as a provider, train yourself to every time ask the questions the same way, is this your current medication list? Is there anything else that you're taking? Anything over the counter, like Tums or allergy medicines? Do you take ibuprofen? Are you on any herbal or nutrition supplements? Are you taking vitamin D or a multivitamin? Anything? Is there anything you take you feel that is helpful to your health? Are you on ashwagandha? Are you on X, Y, and Z? Taking the time to ask and be aware and have an accurate medication med rec every time you go to interact with a patient will save patients and improve outcomes. And it is one of the most overlooked things that happens so easily. So just as the same for everything else, this is important because now we have to remember as well, we also have to have an accurate history of their nutrition and dietary and alcohol, drugs, tobacco, caffeine. When we talk about nutritional management, we are saying that we as providers and prescribers have to have an understanding of nutrition in general in order to prescribe safely. So there are approximately 50 essential nutrients that must be acquired in the diet in order to be in good health, right? So it's vital that you as a provider and a prescriber will understand this and include recommendations about how to integrate a healthy diet into your plan of care. The provider then must become skilled in accurately advising the patients about the benefits of nutraceuticals in maintaining their health or preventing or treating certain diseases. So the information that you gather during your patient interaction should include, again, these complete histories that we're talking about. One of the things you can look at is anthropometric measurements. Usually it's like bicep circumference. Obviously, we have a really good physical exam, and then we can also use labs to help supplement their a reflection of their nutrition. If you, like we said, we're going to phone a friend, right? And really make sure we listen to the wisdom of our pharmacists and dietitians. If you guys have not heard of Aspen, this is your introduction to it, especially if you're ever in an ICU and you're doing different nutritional things in an ICU. It is the American Society of Parenteral and Enteral Nutrition. They are phenomenal, and right along next to them is the Academy of Nutrition and Dietetics. This used to be the ADA, which is the American Dietetic Association. It is now the AND, American Academy of Nutrition and Dietetics. Okay. Aspen guidelines are great. You can always go there. They give all the right recommendations and up-to-date things. And they give us clinical practice guidelines that are the most evidence-based practice. This talks about some of the guidelines and position statements that the American Academy of Nutrition and Dietetics have taken. Infants and children, including adolescents, need 400 international units per day of vitamin D. And then women of childbearing age should be taking 400 micrograms per day of folic acid. Ideally, women of childbearing age should have a steady state of folic acid supplementation long before they get pregnant to have the best outcomes. Oftentimes what happens is women are not taking their folic acid and then they don't find out they're pregnant till they're like 6 weeks. And so those first 6 weeks of critical development have already occurred with low folic acid levels. And then pregnant women need 600 milligrams a day of folic acid and a multivitamin. They need 27 milligrams a day of iron, or up to 60 if they're already anemic, and they need vitamin B12 if they're vegan or lacto-ovo-vegetarian. Adults over the age of 50 need 2.4 micrograms per day of vitamin B12 and an adequate vitamin D and calcium supplement. Patients at risk for suboptimal vitamin D levels should consume vitamin D fortified foods or take a supplement. Patients with age-related macular degeneration need antioxidant, vitamin, and mineral supplements. Next, nutraceuticals. Okay. So nutraceuticals can also be called functional foods. I hear functional foods a lot more than I hear the term nutraceuticals in practice for me. So functional foods and nutraceuticals can be interchanged terms. So we're saying that there are foods that can have medicinal effect on our health. So there is a strong movement in functional foods. And again, excuse me as a provider, I 1,000% agree with this. You may find some people in your practice that kind of feel still like this is kind of hogwash because it's kind of a new age thing. But I totally support it. And I think that there's great evidence and I've seen it in practice myself. So there's really 5 major categories that we use, especially in primary care. So dietary fiber, vitamins and minerals, fatty acids, the bioactive substances of fatty acids, and the pre and pro and symbiotics. Okay. Then we also have plant sterols. Okay. I do want to put in my disclaimer here. I am not saying that everybody needs to be on a prebiotic or a probiotic, right? I'm not saying that everybody should take a fatty acid. I'm not saying that I agree that everybody should just flat out go out and buy these in bulk, right? What I'm saying is that there is a lot of literature to support functional foods, and feeding our body the right quote unquote food medicine is effective in a lot of different ways. Okay. However, just like everything else, they have to be used in the right way for what the patient needs. Not everybody needs the same thing. So the first one is fiber. Fiber is the term used to describe the substances in plants that the body cannot digest. Okay. So in other words, when you take in fiber, you are taking in part of a food that your body is not going to digest. Ergo, you need to have a bowel movement to excrete the fiber that you ate. Okay. So it makes sense that a diet high in fiber is going to produce poop. And that stool is going to decrease constipation because you're going to be making more and it's going to be working its way through. Okay. According to the Institute of Medicine back from 2005, they defined it as dietary fiber and then functional fiber. And I really want you guys to understand this because you need to be able to speak accurately to this in practice. Okay. Dietary fiber is the non-digestible carbohydrates and lignin parts of the plant that are intrinsic and intact. Okay. Functional fiber is the non-digestible carbs that have the benefit effect in human beings. Okay. The total fiber in a product is the sum of both of these. The adequate intake recommendation for fiber is based on the amount needed to decrease chronic disease and increase physiological functioning. It is a huge component of how you treat constipation. Okay. There are controlled trials in children and patients with chronic idiopathic constipation that demonstrate a decrease in constipation will occur with an increase of fiber in the diet. The American College of Gastroenterology recommends increasing fiber intake to prevent constipation. Okay. We also know now that fiber may, quote unquote, lower cholesterol, improve our cardiovascular health, and provide a feeling of fullness that also aids in weight loss. The National Health and Nutrition Examination Survey demonstrated a reduced lifetime risk of coronary heart disease and a lower CRP level, suggesting lower inflammation, with an increased fiber diet. So, because of that information, the American Heart Association recommends increased fiber of at least 25 grams per day for cardiovascular health. So just by functional food and purposely ingesting food to fuel our body, but also give us the function our body needs, you can improve and reduce your cardiovascular risk factors with a 25 gram per day 25 gram per day fiber diet to decrease cardiovascular risk, improve our cardiovascular health. Now, I don't know about you guys, but if you've ever paid attention to your nutrition, it is really important to look at how much we are actually taking in of fiber a day. There's lots of data to support that on average, adults in America do not get anywhere near 25 grams of total fiber a day at all. So if you were to have 1 cup of avocado, you are only getting 10 grams of fiber. If you have a pear, it's 6 grams of fiber. An apple tends to be about 4 to 4.5 grams of fiber. Brown rice is 4 grams per cup. Actually, believe it or not, popcorn is 4 grams per cup. Split peas are 16 grams per cup, and lentils are 18 grams per cup. Right? Chickpeas are 12 grams per cup. Carrots, you would need to eat a cup of carrots to get 5 grams of fiber. Quinoa, 5 grams in a cup. A banana, you would need a cup to get 4 grams. Oats have 5 grams per 1 cup. Almonds, you can get 6 grams per 2 tablespoons. So a good handful of almonds will give you 6 grams of fiber. Okay. So I say this because it's really important to understand you don't always get a lot of fiber in your diet very easily. Okay. And this means that you have to be intentional about your fiber. Okay. I do challenge you guys over the next week after listening to this lecture, track your fiber. See if you get anywhere near 25 grams a day of fiber. The next thing about fiber is that it gives better glucose control and improved lipids in patients with diabetes. This has been well known and studied. It also can decrease the risk of kidney stones in postmenopausal women, and it causes less periodontal disease and tooth loss. Honestly, something as simple as intentionally changing your diet to give yourself 25 grams of fiber in your day can have a marked improvement on your overall health over time. That is something that is not a foreign drug, right? You're not adding new chemicals to your body or taking meds, right? You're not adding something foreign. All the foods that are high in fiber are also good for you for every other reason, right? I didn't list on there McDonald's French fries as 10 grams per large, right? No. The foods that are naturally occurring that are high in fiber are also good for you in every other way. They're going to have other health benefits. So if you were to just do an improvement in your diet to the majority of the time, the majority of the week, you get really high fiber in your diet, that is functional food, you guys. That is something that is hugely going to impact your, your overall health. But it is not in the American way. Oats, quinoa, split peas, those are things that are going to need to be bought and made and prepared. They're not in fast food. They're not in our pre-made dinners. They are tough things to have happen because they take time and effort and eating clean to obtain. Next one, we go to vitamins. So the vitamins and minerals are the most widely used supplements. They're a huge money maker across America. When they are ingested as part of a food source, they're considered a nutraceutical. We have our recommended daily allowance for these different vitamins. So the first one, vitamin A. This is what we think of when we talk about our vision, right? You need vitamin A for good, healthy eyes, but it's also needed for bone growth, reproduction, your immune system, and cell division and differentiation. There are two types of vitamins, okay? We have preformed vitamin A, which is derived from animal sources. And so that is also called a provitamin A carotenoid. So that's from plant sources. Vitamin A is stored in the liver, and it's retinol esters in the liver. So a healthy diet should contain a variety of carotenoid-rich fruits and vegetables. To be deficient in vitamin A is rare in the United States, but we do still have vitamin A deficiency in developing countries. Serum retinol and carotenoid levels are measured in the plasma, so we can use that to assess vitamin A deficiency, but it doesn't help us measure the vitamin A that's stored in the liver. If someone is deficient in vitamin A, they can have night blindness, xerophthalmia, or decreased immune function. Vitamin A may reduce the severity and duration of diarrheal episodes in malnourished children in developing countries. Vitamin A supplementation has also been found to decrease bronchopulmonary dysplasia in extremely low birth weight infants. For us as adults, we need to remember that chronic alcoholism can lower our vitamin A levels, so patients with chronic alcohol use disorder may require vitamin A supplementation. Patients with cystic fibrosis also are predisposed to malabsorption and fat-soluble vitamin deficiency. So about 10 to 40% of people with cystic fibrosis can be deficient in vitamin A. All children with measles are recommended to be on vitamin A supplementation, regardless of their nutritional status. It's also a good one to know. You can have toxicity, so remember that levels above the recommended amounts may be teratogenic in pregnant women. Preformed the vitamin A is teratogenic if intake is greater than recommended amounts. So it's a good thing, but there is such a thing as too much good. And you can have too much vitamin A and have some pretty severe side effects from that. So you would not want a pregnant person on a vitamin A supplementation, right? Like I said, most of us get the adequate amounts in our diet, and if they're eating a well-rounded diet, they're going to have enough. You don't want them to be on a vitamin A supplement. Oh, sorry. Next is vitamin B1 thiamines. Please, please, please have an understanding of all the different vitamin Bs, 1, 6, etc., and what they are. So vitamin B1 is thiamine. When you're deficient in thiamine, you can get Wernicke encephalopathy or beriberi. Okay. Vitamin B is a water-soluble, vitamin B1 is a water-soluble vitamin, meaning it likes to live in water, and it can be broken down in water, and it's critical for many body functions, and it's widely available in our American diet because it's in fortified breads and cereals. Early thiamine deficiency can lead to weight loss and anorexia, memory loss, and muscle weakness. But if you have chronic deficiency, that can be the beriberi, which causes neuropathy and wasting, or Wernicke encephalopathy. So patients with alcohol use disorder will develop thiamine deficiency at 8 to 10 times the rate of the population that don't use alcohol. Okay, we know this. We give everybody a banana bag with thiamine in it, right? Up to 80% of patients with chronic alcohol dependence will develop thiamine deficiency at some point. This is because of the impaired GI absorption of thiamine in their diet. There's other groups at risk for vitamin B1 deficiency, and that can also include HIV or AIDS, diabetes, and then gastric bypass surgery. We know that beriberi and Wernicke can be a very serious neurologic illness, especially Wernicke encephalopathy, and you need to have immediate repletion of their thiamine with high dose levels of thiamine. Usually we give 500 milligrams IV 3 times a day times 2 days, then 500 milligrams per day, either IV or IM, for another 5 days. Patients should still be given a 100 milligram dose of oral thiamine until no longer considered to be at risk. Mild thiamine deficiency is treated by administering 10 milligrams oral daily for a week. And then you do 3 to 5 milligrams daily for 6 weeks. All right, vitamin B2 is riboflavin. Vitamin B2 is a water-soluble vitamin. It's found in eggs, organ meats, lean meats, milk, and then it's also fortified in our breads and cereals. It is rare to have riboflavin deficiency, but it can be seen in patients with alcoholism, anorexia, and those with lactose intolerance who do not drink milk or consume dairy. Vegetarian athletes specifically are at risk of vitamin B2 deficiency due to their increased need for riboflavin in their diet. And so they have a diet that excludes meat sources, right? Pregnant women who do not consume meat or dairy can also be at risk. Riboflavin has been found to decrease headaches and migraines in some patients, so they think that maybe there's use to have it as a supplement in that way. There's an over-the-counter product called MigraLeaf that contains feverfew, riboflavin, magnesium, and some other vitamins that can be used daily to prevent headaches. There are no risks in excessive intake of the water-soluble riboflavin, so you really can't overdose on vitamin B2. Next, then, we have vitamin B3, which is our niacin. Again, it's water-soluble, and it's considered an anti-lipidemic, which is great. So helps us get rid of fat. Most Americans consume more than our recommended daily allowance, but you can still have niacin deficiency or pellagra that can be resulting from inadequate intake, particularly in extreme poverty or severely restricted diets that are low in protein. So serum levels of niacin are not an accurate measure of niacin deficiency. You need to have urinary excretion tested to actually measure your niacin status. Pellagra is when you have pigmented rash or brownish discoloration of the skin that's exposed to sunlight and may develop a sunburn-like appearance. You can also have bright red tongues, vomiting, constipation or diarrhea, and neurological symptoms like depression, headache, and fatigue, or loss of memory and even hallucinations. Pellagra can be fatal. So you have to have enough vitamin B3. We also use niacin in the treatment of hyperlipidemia, and we'll talk about that way far down the line when we get into cholesterol. All right, next we go to vitamin B6 peroxidine. Vitamin B6 is also water soluble, and we need it for protein and red blood cell metabolism. We also need it for glucose regulation. Vitamin B deficiency may lead to microcytic anemia, depression and confusion, or dermatitis with cheilosis, which is the scaling of the lips and cracks of the corner of the lips, or glossitis. Vitamin B6 deficiency is one of those ones that actually can be induced by a drug like cycloserine, or some of the antiepileptics like valproic acid or carbamazepine or phenytoin, or if you have a diet that is deficient in foods containing vitamin B6. Good news is it's fortified in cereals, potatoes, bananas, it's fortified in cereals, but it's also found in potatoes, bananas, and meat. Patients with chronic renal disease or chronic autoimmune disorders like RA or Crohn's, or alcohol use disorder people can be at risk for deficiency of vitamin B6. We also want peroxidine or vitamin B6 should be given orally and added to the regimen for pregnant patients if they are taking isoniazid to decrease the incidence of peripheral neuropathy associated with taking isoniazid. Some people take prophylactic peroxidine to treat their peripheral neuropathy. And then sometimes people take a vitamin B6 supplement to reduce the symptoms of PMS. And then some people think it's been shown to help with preventing nausea and vomiting associated with pregnancy. Vitamin B12, right? We know all about vitamin B12, hopefully, from pathophysiology. Again, it's a water-soluble vitamin, and it's essential for red blood cell formation, DNA synthesis, and neurologic function. Vitamin B12 is essential for red blood cell formation, DNA synthesis, and neurologic function. Vitamin B12 is essential for red blood cell formation, DNA synthesis, and neurologic function. We can measure it in the serum or plasma. Okay. Typically 200 to 250 is considered the low end. Deficiency can be very problematic. It can cause megaloblastic anemia, fatigue, weakness, constipation, and weight loss. There also could be an association between vitamin B12 deficiency and depression. Older adults and patients who have had gastric bypass, patients with reduced stomach acid levels, and patients with intestinal disorders, specifically celiac and Crohn's, may not absorb vitamin B12 well and could become deficient. Also, people who are strict vegetarians or vegans can have vitamin B12 deficiency. Breastfeeding women who are also strict vegans without supplementations can place themselves and their breastfed infant at risk for vitamin B12 deficiency, which will lead to possible developmental delays or failure to thrive in the infant. Acid suppression medications then also could be problematic, right? So think of our PPIs or H2 antagonists, so famotidine or pantoprazole, or even being on metformin can reduce the absorption of vitamin B12. Vitamin B12 deficiency is treated with injections or very high dose oral supplementation, and we'll talk about this further when we get into anemia. Next, we come to vitamin C, which is ascorbic acid. It is also water soluble, and it is a vitamin that we as humans do not have the ability to synthesize. So we have to have adequate amounts in our diet. Patients with inadequate vitamin C may develop scurvy, and that can cause symptoms of fatigue, malaise, or gum inflammation. As patients get worsening deficiency, they can develop joint pain, ecchymosis purpura. They'll have poor wound healing and corkscrew hairs. Scurvy is rarely in developed countries anymore. Whenever I think of scurvy, I think of the men on the boats and the pirate ships back in the day, that they would be at sea for so long without fresh fruit or vegetables, and they would get scurvy. And the other thing to remember is smokers or people who are heavily exposed to secondhand smoke have decreased vitamin C levels, so they should be on a supplement. Other groups at risk for vitamin C issues will be infants fed evaporated milk or boiled milk, or patients with malabsorption disorders, and patients with end-stage renal disease that are on hemodialysis will be on a vitamin C supplement. Vitamin C does not decrease the incidence of cardiovascular disease or cancer. That's been studied extensively. Next, we get into vitamin D. Vitamin D, for many years, I want to say it was like 2010 to 15, I just remember there was this huge boom in vitamin D. It was in every journal. It was in every conference I went to. Vitamin D, vitamin D, vitamin D. It really became the hot thing to be on, was vitamin D supplementation. Vitamin D is also known as calciferol. Okay, vitamin D is a fat-soluble vitamin that's available in some foods like egg yolks or fatty fish. Specifically, mackerel and salmon are really good sources of vitamin D. Understanding vitamin D and how it's critical to bone health and as an immunomodulator is very important. So we have to understand how the body uses vitamin D. So our body synthesizes vitamin D when sunlight strikes the skin, and that is literally what triggers vitamin D synthesis. So people that live in areas of low sunlight can easily become deficient in vitamin D. So vitamin D supplements and food sources and the vitamin D synthesized from the sunlight must then be converted to the active form in the liver and kidneys. So when we take it in, it's calciferol. Then the liver converts it to vitamin 25 hydroxyvitamin D, which is often 25-OHD. Or it's called calcidiol. And then the vitamins will convert vitamin D into calcitriol. So vitamin D is required for the absorption of calcium from the intestinal tract. When vitamin D is converted to the calcitriol in the kidneys, it will regulate serum calcium and phosphate levels. So vitamin D is a critical component in our diet or in our body. We have to have it. It is a critical component in bone growth and remodeling. So if you are deficient in vitamin D, you will get brittle bones that can become misshapen. And this is what was known as rickets in children. And we can also see it in adults as osteomalacia. The vitamin D status is measured by your 25-OHD serum concentrations, right? So we want to measure the level of vitamin D that's been converted in the liver. The American Academy of Pediatrics increased the recommended vitamin D intake for infants and children due to multiple repeated studies that showed children and adolescents were chronically deficient in vitamin D. So now, breastfed infants require 400 international units of vitamin D per day, or the maternal intake of 6,000 international units per day. Children aged 12 months through 18 years need 600 international units daily, and should have supplementation if adequate amounts are not consumed from dietary sources. That's their statement. That's their statement on vitamin D. How many of us are actively checking our children's vitamin D levels for routine screening? None. In 2020, they published that the studies were showing up to 40% of infants were still not receiving the recommended amount of vitamin D. We also now know that vitamin D has been linked to increased incidence of asthma. So we're beginning to see that not having enough vitamin D can be very problematic. The use of oral corticosteroids will place the patient at 20 to 40% higher risk of vitamin D deficiency. So if they're on chronic steroids, we need to pay attention to the vitamin D. Here's where this next one is what I would say is still something that people don't seem to know about vitamin D in healthcare still, is that vitamin D is an immunomodulator. So it can alter the development of immune cells. It can reduce airway remodeling and the inflammatory response, and it can improve our eosinophil function. And it inhibits fibrotic mediators. So there's still a lot of studies going on about this and the role of vitamin D. Vitamin D supplementation then can improve asthma symptoms. And if you are asthmatic and you become deficient in vitamin D, you're likely to have worsening symptoms. The good news is that vitamin D is added to milk and infant formulas and dry cereal. So that's nice. We tend to be getting it without even knowing it in some of our supplemented foods. Next is vitamin K. Vitamin K, fat soluble, and it's a critical component of blood clotting. Vitamin K, fat soluble, and a critical component of blood clotting. It's found in many foods, and it's synthesized by our intestinal bacteria. So there are two types of vitamin K, vitamin K1 and K2. K1 is phylloquinone. Those are your green leafy vegetables. And K2 is your menaquinones, which are bacterial origin and found in animal-based and fermented foods. Vitamin K deficiency is rare beyond the newborn period, but it can be found in some malabsorption disorders. Newborns are at risk for early vitamin K deficiency bleeding because they can have poor transfer across the placenta during pregnancy. So that is why the American Academy of Pediatricians still recommend IM vitamin K administration due to poor protection against bleeding at birth. We know that warfarin interferes with the vitamin K dependent clotting factors 2, 7, 9, and 10. So it can lead to decreased formation of clots. Vitamin K, which is phytonadione, I can never say that, is prescribed for patients who develop a critically high INR. Patients with an INR greater than 10 without evidence of bleeding can be administered oral vitamin K. If the INR is high with bleeding occurring, vitamin K IV is administered, often along with prothrombin complex. Which is listed there. Next is folate. Folate is a water-soluble vitamin, critical to the production of nucleic acid, RNA and DNA, and metabolism of our amino acids, and to maintain new cells. Folate is water soluble, and it's critical to the production of RNA and DNA. It's critical to metabolism of amino acids, and it's critical to the maintenance of new cells. Folate is found in foods like green leafy vegetables, our citrus fruits, and our dried legumes. Folic acid, which is the synthetic form of folate, is added to bread, flour, pasta, rice, and some other grain products. When you are folate deficient, that's a problem. Folate deficiency occurs in times of increased demand, so typically think pregnancy or lactation, or when loss increases. So if you are doing if you have conditions where you're chronic alcohol use, you're on dialysis, you have a horrible liver, or malabsorption issues, you're oftentimes folate deficient. There are the medicines that lead us to being deficient in folic acid, and that's in box 7.1 on your book. So these main ones we think about are methotrexate, but I also want to point out metformin. I don't know that metformin always gets the bad association with decreased folic acid. But also triamterene is an old diuretic. Trimethoprim is what we see in Bactrim. So it's out there. We need folate for normal maturation and function of our red blood cells. So if you are deficient in folate, you can get a megaloblastic anemia. Patients with folic acid deficiency will complain typically of stomatitis, glossitis. Some have anorexia, nausea, and diarrhea, or some can also cause a systolic ejection murmur. We know that oral folic acid is well absorbed, so we can replete it orally. Hemoglobin levels will begin to rise within the first week. And typically within 1 to 2 months, you've corrected your anemia. So we've covered our vitamins. Next, we get into our minerals. Calcium is a critical mineral in the function of the body. It's needed for muscle contraction, blood vessel health, bone health, and nerve conduction. So if someone were to ask you, why do we need calcium? You would say, well, that's easy. We need it for muscle contraction, blood vessel health, our bone health, and our normal nerve conduction. One of the really important things is we have to maintain the appropriate levels of calcium. So to find that balance, we need to have an adequate relationship and adequate stores of calcium and vitamin D, and an endocrine system that's functioning appropriately to keep our calcium in check. When you have dietary intake or an increase in how much we're consuming of calcium, the calcium from bone tissue is going to be released to maintain our serum calcium levels. Serum calcium levels will measure approximately 1% of the calcium in the serum, not our total body stores, because 99% of our calcium is stored within our bone tissue. Say that again. When I measure serum calcium, I'm only getting a reflection of 1% of the total body store of calcium, because we will hold 99% of our calcium in our bone tissue. Important to remember. People are at risk for calcium deficiency, and those are postmenopausal women, women without a period, amenorrheic women, women with female athlete triad, people who are lactose intolerant, vegans, and those who avoid dairy. Okay. The study from 2007 to 2010 showed 49% of children from the age of 4 to 18 consumed inadequate amounts of calcium in their diet. Also, 39% of people over the age of 4 reported inadequate calcium intake in another study. Calcium absorption is varied with the type of calcium consumed and the age of the person ingesting it. So the phytic acid and the oxalic acid found in some plants will decrease calcium absorption. When you're an infant and a child, you can absorb about 60% of the calcium you take in your diet, but as we age, we get down to 15 to 20% absorption. Calcium absorption is enhanced when the supplement is taken with food. We will talk a lot more about calcium also when we talk about osteoporosis in further chapters. Next is iron. Iron is an essential mineral required for the growth of cells and cellular differentiation, as well as iron transport. I know you guys know this from when we were in pathophysiology. Okay. So people with iron deficiency will develop a microcytic hypochromic anemia. So that means their red blood cells are small, they're pale, and they're low in hemoglobin. Iron deficiency anemia reduces the oxygen carrying capacity of the blood. That's going to mean you have fatigue and decreased immunity. Serum ferritin measures the body's iron stores, and a serum ferritin level lower than 30 indicates iron deficiency, and typically levels are less than 10 in iron deficiency. Iron deficiency people are at risk for iron deficiency if they're going through periods of rapid growth. So infants or young children, pregnant women, and then female adolescents. Also, people are at risk for iron deficiency if they're bleeding, such as women with heavy menstrual bleeding, frequent blood donors, and patients with cancer, GI disorders, or previous bowel surgeries. The interesting thing about iron is that too much iron can lead to iron toxicity, so you should pay attention to only taking the right amount if you need it. Last but not least of the vitamins, minerals, now we're down to fatty acids, essential fatty acids. Fatty acids are needed to be consumed in food, or we need them via supplements, as the body does not make them. Again, the body does not make fatty acids. We must consume them in food or supplements. Okay. Let's break down fatty acids a little more to understand the differences, because there's a lot of names floating around fatty acids. Okay. You will see acid alpha linoleic acid, ALA, and that's a polyunsaturated fatty acid ingested in the diet and is an omega-3 fatty acid. Linoleic acid, LA, also ingested from the diet, is an omega-6 fatty acid. Omega-3 is converted to EPA, eicosapentaenoic EPA, and DHA in the body. Okay, so essential fatty acids we have to have consumed. We don't make them. ALA is ingested in the diet, and that's an omega-3 fatty acid. LA is ingested in the diet, and it's an omega-6 fatty acid. So ALA, the omega-3 fatty acid, is going to be converted to EPA and DHA in the body. Most Americans will consume more omega-6, which is the LA, than we will consume omega-3, the ALA. But actually, consuming more omega-3 over omega-6 is what is recommended. Dietary sources of ALA omega-3 include nuts, vegetable oils, leafy green vegetables. But LA omega-6 is found in vegetable oils and meat. You can have great sources of EPA and DHA in fish and organ meats. Okay. Omega-3 fatty acids and heart disease is a big deal. There's been studied ad nauseum in this. Okay. What they found is a dose-response relationship with blood pressure is one of the big things that they found. Omega-3 supplementation did not reduce combined major cardiovascular events like stroke, MI, or dying from heart disease. But the participants who were taking omega-3 had a significant reduction in total myocardial infarction rates and fatal MIs. The ASCEND study involved more than 15,000 adults of 40 or older with diabetes, and that found that the omega-3 supplementation did not reduce the risk of a serious cardiovascular event, but it did reduce the risk of cardiovascular death over placebo. Then, a meta-analysis of the 71 trials examining the association of omega-3 fatty acids and blood pressure did reveal that dose-related response. So, omega-3 fatty acid supplements lowered blood pressure at 2 grams per day and 3 grams per day. Omega-3 fatty acids have recently received attention as a possible treatment for autism and ADHD. The theory is that deficiency in omega-3 or an imbalance in omega-3 to omega-6 ratio will affect the neurocognitive development in children. It's clear that sufficient amounts of the essential fatty acids are crucial to central nervous system development. So with deficiency or an imbalance found in multiple observational studies with children with neurocognitive issues, that's leading people to think that adding DHA and ALA to commercial infant formulas to meet the need in key development periods of infancy is a good idea. A comprehensive review of 95 randomized controlled trials and 48 prospective longitudinal studies of maternal intake of omega-3 fatty acids during pregnancy and lactation concluded there are no consistent health outcomes with supplementation other than a small effect on infant birth weight. Numerous studies of the use of omega-3 fatty acids in children with ADHD demonstrate improvement in ADHD scores. A systemic review and meta-analysis of the effect of omega-3 supplementation on emotional ability, oppositional defiant behavior, and conduct problems in children with ADHD did not find large effects. However, the study did find small effects on emotional ability and oppositional defiant behavior in children with ADHD who are supplemented with omega-3 fatty acid. So, it's important that the need for essential fatty acids in neurologic development is critical to ensure a diet rich in fatty acids throughout infancy and childhood. However, it is not true that fatty acids prevent or treat Alzheimer's or macular degeneration or inflammatory bowel or cancers. You can get the recommended amount of omega-3 fatty acids in your diet by eating fatty fish or taking fish oil capsules. The American Heart Association recommends 2 servings a week of fatty fish, such as salmon, mackerel, herring, lake trout, sardines, or albacore tuna for heart health. All right, next is plant sterols. These are found in all plant-based foods as part of the structural component of the cellular membrane. Plant sterols are similar in structure to cholesterol, but contain an extra methyl or ethyl group. When consumed in the diet, plant sterols compete with cholesterol in the intestine. So that's going to reduce the amount of cholesterol that is absorbed. Yay! So an intake of 2 grams per day with associated 6% to 10% reduction in LDL was found. So combining plant sterols with your cholesterol-lowering medications can give you 16 to 20% reduction in your LDL. The only adverse effect of plant sterols is reduced beta-carotene levels, but that can be treated with an increased intake of carotene-containing fruits and vegetables. Plant sterols are present in corn oil, canola oil. Those are the two highest. We can get it in seeds and nuts, as well as vegetables like broccoli and Brussels sprouts are the highest levels. And then our fruits. The specific fruits are blueberries, raspberries, and avocados. There are many commercial food products available, like margarine will have added plant sterols to it, and then some milk. Guidelines for children and adolescents is that plant sterols up to 2 grams per day can be used as a replacement for the usual fat sources after the age of 2 in children with familial hypercholesterolemia. Plant sterols may be combined with a low saturated fat and low cholesterol diet, dietary fiber, and or lipid-lowering drugs for an additive effect on our LDL. Next, prebiotics, probiotics, and symbiotics. Here is my little thing to say. As of right now, talking about this in 2025, I will say, in my opinion, just little old Sawyer's opinion, I could go right now and I could take 20 internists and bring them into class and ask them their opinions on this. And I think that we would get 10 that will rave about the importance of prebiotics, probiotics, and symbiotics and supplementation, and they're just the most beautiful thing ever, and everybody should do it. And then I think we would get 10 that are going to tell you absolutely not. If you eat a good diet high in fiber and you eat healthily, you do not need any other prebiotics or probiotics. And then there's studies that sit in the middle, okay? So there is a lot of opinion on these topics. So when we talk about it in class, I feel like I'm obligated to tell you, you're going to get mixed views in your clinical rotations or experiences for yourself, in my opinion. So let's talk about this. The probiotics are non-pathogenic bacteria, which is normally found in our intestinal microflora. So the most common probiotics are Lactobacillus acidophilus and Bifidobacterium species. Prebiotics are non-digestible food ingredients that stimulate the growth of probiotic organisms. The symbiotics are a mixture then of probiotics and prebiotics. Probiotics are used to restore the normal balance of gut flora that is distributed with that is disturbed when you take antibiotics, immunosuppressives, or for certain other medical conditions. Is there a role for probiotics? Absolutely. I'm not arguing that point at all. Probiotics are also thought to enhance the intestinal immune response. Probiotics are thought to block the adhesion of pathogenic bacteria in our intestinal epithelium. Probiotics are thought to upregulate intestinal electrolyte absorption, and they think probiotics will repair intestinal permeability. So probiotics have been studied and used for many, many years, and we have seen health benefits on effects of diarrhea. So many studies suggest that the use of probiotics in acute diarrhea in children found a reduced diarrhea severity and duration. Okay. We also know that probiotics also reduce antibiotic-associated diarrhea in adults and in children. We know through meta-analysis studies, time and time again, that probiotics reduce C. diff infections compared with placebo. So it is reasonable to prescribe probiotics for patients with infectious or antibiotic-induced or associated diarrhea. Absolutely. I don't think anybody's going to argue that point. That is well studied, well documented. Patients should start probiotics on the first day of their antibiotic therapy or at the start of acute diarrheal symptoms, and then continue for up to 2 weeks after the antibiotics are finished. Because we know that they are going to help restore the healthy gut flora that could be disturbed by antibiotics. Okay? We also know that probiotics can improve inflammatory bowel disorders and necrotizing enterocolitis, NEC. Increased remission rates have been reported in patients with ulcerative colitis when probiotics are started and continued after exacerbation for 2 weeks. Perfect. Premature infants have sterile guts at birth, and they're at risk for bowel problems, right? So we have found in studies that giving those people probiotics can be beneficial. Okay. Probiotics given right after birth have been shown to be helpful. Probiotics are helpful in patients with irritable bowel syndrome by decreasing the symptom severity. And probiotics have also been used and found to help eradicate patients being treated for H. pylori. Okay, all of those things are fairly well documented. I don't think you're going to find anybody that's going to argue those things. The next thing is people think and talk about constipation and functional abdominal pain. These are very challenging disorders to treat and to help people not have significant decrease in quality of life. So there has been some evidence to suggest that probiotics in children and adults with IBS or really bad constipation or functional abdominal pain may benefit from probiotics. Okay. That's what your book talks about. What I'm trying to tell you is if you go to the literature and we look up, for example, we look up prebiotics, probiotics, should everybody be on these antibiotics? Okay. You're going to find a wide variety of opinions. This is where I'm talking about people having strong opinions. You will run into medical people that are going to tell you that everybody should be on a prebiotic and a probiotic. That everybody should be taking these. To not take them is the stupidest thing ever. X, Y, and Z. Outside of the diseases that we have talked about, you are not going to find that it is recommended that everybody be on them. My personal opinion of where I fall in the literature these days and from what I've read and all those things tells me that not everybody needs to be on a prebiotic or a probiotic, but they are very helpful for certain conditions. I do think that people on antibiotics, it is very reasonable to prescribe them the appropriate probiotic, such as the Lactobacillus acidophilus. It's also really important that people have the normal fiber in their diet that is going to maintain a nice, healthy gut flora. All right. Knowledge check. The most frequent type of drug-food interaction is the effect that food has on which of the following? Conjugation, excretion, metabolism, or absorption. If you picked D, you are absolutely correct. Which of the following is most important for effective clinical decision-making regarding nutrient-drug interactions? Consult health food stores, use current resources on drug-food interactions, get a complete list of the patient's prescribed drugs, or provide the patient with the prescribed drug package insert. This is a trick question, everybody, because the book's answer is B, of course. However, Dr. Becker's also answer is that it should be select all that apply, and it should be B and C. But the book's answer is B. Thank you for making it through the lecture with me for Chapter 7, and we'll see you in Chapter 8.